Identity, HPV, sexually transmitted disease.
They're only there for pain. That would have, see, that's the
treat me, you have to know who I am. I identify as the Latina lesbian mother.
Can you guys see
To
it?
treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man.
When I was about 15 years old, I remember going to the doctor's office, and I remember telling her when she asked about my sexual activity, if if I use condoms or anything like that, and I said, no, I'm gay, and I just remember her face changed very much, and her warm tone of voice turned very harsh. And it seemed as though she was rushing me out as quickly as possible.
I do think the LGBT community has special needs. I think the LGBT community has a specific special, which is to be treated in a way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of the answers.
My partner and I and our children were on a family vacation, and my older daughter became sick. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
My partner was hospitalized recently. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I would.
Oh gosh.
Allowed.
My name is Leo Sell, and my pronouns are they, them, their.
My name is Sophia Stanford, pronouns she, her. I'm Greg, and my preferred pronouns are he, him.
Robin Kanawahasa, and I use feminine pronouns, so she, her, hers.
My name is Luke Jude, and I prefer he, him pronouns.
My name is Chloe Flora. My preferred pronouns are she or they.
.99% of the time when I go to the doctor, I'm anxious and nervous.
Even though insurance and driver's license and everything says female, you really don't know what to expect.
Yeah, I don't think I know any trans person that went to the medical system and had a nice time with it. Not in this country.
I haven't gone to the dentist in 4 or 5 years because it's just such an uncomfortable experience.
I know people who, if they sprain their ankle, will just wrap it up and put some ice on it rather than going to the ER and having an x-ray done because it's just not worth the stress.
I've had a history of urinary tract infections. It was pretty commonplace for me. And I went to the urgent care, and the physician on staff that I was dealing with kept telling me over and over how atypical it was for a man to be having a series of urinary tract infections. I tried to interrupt him and say, I understand, I've been through a gender transition, so my anatomy is probably not what you expect it to be. And he kept stopping me. He wouldn't let me complete and assuring me that he did understand. And he said, I think I would like to take a look. So I pulled down my pants. And it wasn't at all what he expected. And he was immediately apologetic. He said, oh, you don't have, I'm so sorry, I didn't realize. I said, I know, we tried to tell you.
I initially knew I identified and felt female around 5 years old when this was caught out by my family member who was the director of mental health for the state that I lived in. Essentially required forced correction, like invasive hypnotherapy, corrective assignment, and orientation to gender roles, other things to help masculinize and or reprogram the viewpoint of the world to the child. If I have to be this way, I'm going to walk in front of a car and I'm going to reset it and try over. That's what I thought when I was 6.
I had a bunch of different symptoms tied to sleep, tied to appetite, weight gain, mood that had sort of increased in severity over a year. And one of the things that my doctor told me to do was check myself into a hospital next time I had my round of symptoms. So I checked into a hospital, and even just within the check-in process, I was misgendered. I finally spoke to the doctor, and he came in and was speaking to me as if I was a 13-year-old girl. And all of my symptoms were surrounding hormones. And when I started talking about hormones, this doctor in the hospital actually looked at me and said, "Oh, what do hormones do? I didn't think hormones did anything." And he actually checked me out of the hospital. He said, "You know, I think that you're just bleeding a lot right now." Fast forward 3 days later from this hospital visit, and I was diagnosed with invasive hormonal breast cancer that tested 99% positive for estrogen. And I think that if I had had the same list of symptoms, but was a cisgendered man, I would have been treated completely differently.
So in general, I've been blessed with a good primary care physician and an endocrinology doctor, but I was seeing a specialist for a different medical problem, and my records and everything all said female. I have everything changed. And the guy looked at it, he went through all of those steps, and then said, "So, do you dress full-time as a woman?" And I was stunned. It's like, "Do you dress full-time as a man?" Yes, I'm a woman. I'm a woman of transgender experience, and of course, it's just like any other woman in your office.
The biggest horror story that I had was going to the pharmacy to pick up my first testosterone prescription. I was nerve-wracked already because it's like such an emotional thing to like finally get that golden ticket. It's a thing like $1. So it's just the syringes. There's no medicine. 4 people later, in about 20 minutes, they finally look it up in the computer and they're like, "Oh yeah, oops." Throughout this entire process, I have to say my legal name, which isn't the name that I go by, out loud to the entire store. And I'm basically outing myself to everyone around me. And that's not wanting to hide, that's just about trying to stay safe. Like, so people hear that and they might follow me in my car and bash my head in.
During one physical therapy appointment, I had one of the therapists misgendered me to an entire room of people, both other physical therapists and other clients. He never looked me in the eye again. He never talked about it. He never apologized. It was just this weight. And especially me as a trans woman, I get misgendered all the time. Like, it's something I deal with on a near daily basis. So to have that happen in a medical setting, something where I can opt out of, even though it might not be the healthiest thing, I will. I'd rather protect my own sense of mental health.
To accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have different sexual orientation or different gender identity than the care provider.
The people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it.
When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me, even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status. And upon meeting me and learning my transgender status, he decided that his first impulse was to refer me to psychiatry.
It's not about sensitivity, it's about respect, it's about humanitarian response to a human being in general.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
So what do you guys think? Do you think that's happening today? Yes.
I think part of the dilemma is, as a heterosexual woman, sometimes I don't know, and if you don't educate me on who you are, then I see you as a male because that's what I know a male looks like. Not that I'm trying to offend you, not that I'm trying to hurt your feelings, but if you don't educate me on your identity, I don't want to be held accountable or be told I'm mean because I called you a he when you go by a she. Does that make sense?
It does, and that's where I have found that most people that see themselves as something other than their biologic, if you ask and you are open about it, they will answer. I've always asked, what would you like me to call you? And they'll tell you, call me such and such, or they may have a nickname, whatever it is. And you will have patients that come in that you don't know for sure. And it's just like with any other patient. I always ask, what would you like me to call you? And then once you start doing your assessments and you have to build a bond with them, then they're going to be more open about things. And you've got to listen, because what I hear in this is nobody was listening to them. And as nurses, we have to listen to our patients no matter what is going on or who they are. And if we don't do that, they're not going to trust you, and they're not going to tell you. Anybody else? Yes?
Well, as a healthcare professional, a doctor, or nurse, if you click refuse service to someone, someone that doesn't go along with your own religious beliefs or whatever, you can lose your license, right? You can't just pick your patients.
You don't pick your patients. That's where you have to look at yourself and put your beliefs aside. Now, that being said, there are going to be times when there's someone, for whatever reason, you can't take care of. That's when you go to the person that made the assignment and say, hey, look, I'm sorry, I can't take care of this person. Can I trade with someone? And someone will trade with you. And it doesn't come to that. But don't take on something that you know that you can't. And it may just be, for example, I took care of a patient that was an inmate, which to me, we take care of a lot of inmates. I took care of him for 2 weeks straight. And then I found out why he was an inmate. And when I found out he was a pedophile that had continuously raped young girls, I couldn't do it anymore. And it's not because I don't think I could have given the care. It's because my own judgment, and I had to look at myself. And when I looked at myself and I realized I wanted to do something that I couldn't do, someone else switched me. So if it comes to that point where you know there's something blocking you, most of the other nurses will switch. Yes?
And I just want people to know that it's okay to make mistakes with it. I used to work with this kind of stuff, and you guys know I'm gay, whatever, blah blah blah. And even we get confused with it too. So I understand somebody says I'm a cisgendered male, blah blah blah, cisgendered female. Most people are even like, what the hell is he? What does that even mean? So I understand when people sit down and say, especially with trans, are kind of confused. But the best thing to do really is just, if somebody says, my name is Jane, and they look like Jack, just call them Jane. And just kind of keep it kind of moving in that way. It just really is the best thing to do.
And you're correct.
And then just, you will see it on the paper, and you will be able to see it or whatever, but just kind of just call them whatever they want to be called. And that's just the best thing. I mean, they're already used to, people kind of being surprised or whatever, so just...
And you're correct. And usually when you have that approach and you listen to them, they're going to be more open with you. I can't tell you how many patients over my career I've taken care of that I didn't know. I just said, what would you like me to call? I even had patients that would not even let me look at them until we built a bond, and then it became, and we discussed things in their life. But you're going to have obstacles, but if you're open and non-judgmental, most people, no matter what their beliefs are going to overlook that and accept you. And you do make mistakes. And like I was saying, things change. Words change. So, Professor Bell. Yes, I'm sorry. Yes.
So, like, as nurses, we go through different, like, classes and training and stuff to learn how to be socially competent to keep up with the changes that society is making. Does physicians require that same type of training? Because it seems to me that throughout most of these videos, it was the doctor that they had a problem with. It wasn't the nurse or someone that, it was the doctor that had an issue with their sexuality and who they identified as.
Everybody goes through cultural training, cultural sensitive training. Doctors, some, you know, it's the same thing. Some doctors will accept it and some don't. And that depends on the hospital, what's going on, to deal with. But it does happen, you're right. But as nurses, we have to be that line, because we're with the patient all day. And you will have that happen, not even with this involvement. You may have a doctor that may not have been nice to a patient. Your patient's going to talk to you about it, and how you respond to that patient is going to make it better or worse. So, yes.
So what do we do to kind of advocate for the patient if they have a problem with, you know, the PCA or the doctor? Do we go to the nurse manager, or? You
go through the stepping ladder of your facility. The first thing is to talk with your patient, define, and then they have liaisons usually in hospitals where they'll come, patient advocates is another name that they're using, where they'll come and hopefully resolve that. Yes.
I was just saying, as a comment, just so it's not so focused on like trying to figure out what their identity is, you could just group it together with, oh, do you have any cultural, religious, or care preferences that I should be aware of to take care of you? And 99.9% of the time, they're probably going to tell you, oh, I identify as this, because it's in that group. Right. It's not just singling them out.
Right. And that's why, yeah, that's correct. So what other populations might be isolated in the healthcare system that you can think of? Older adults, children, vulnerable people. So the main thing that we have to remember is we have to look at our own feelings first. We have to be able to be therapeutic and non-judgmental on all of our patients. And if you find that you cannot be that, then maybe there's another area that you can be in. Because there's lots and lots of areas in nursing. All right, so we're going to move on to sexually transmitted infections, or STIs. Used to be called STDs, but they've changed it. And STIs are disorders that are transmitted by vaginal, oral, or anal intimate contact and intercourse. Some can be treated and some can be cured. They can be viruses or bacterial. And it's in 1990s when they changed it from STDs to STIs. So what is the concept of sexuality and STIs? Well, you have the science. The science is going to tell you if it's bacterial or virus. It's passed from person to person during sexual contact from the penis, vagina, rectum, or mouth. And then you have the stigma. It's the judgment, being condemned by others. But in reality, STIs are common. It can only take one partner. And many are asymptomatic. Our next clip. Our other article. The poor women with sexually transmitted infections. What did you guys find out about that article? How did the stigma affect the behaviors of the women? Yes?
The women were less likely to even seek treatment if they didn't have health insurance.
Correct. And where was this done at? West Virginia. So what do you associate with West Virginia? Coal. Poor society. Low income. So what did you learn from the reading? Yes?
Sometimes the women couldn't afford the treatment, although they went to, because
lack of insurance, lack of money to have a full-term treatment.
Mm-hmm.
Stigma, because it seems like a more religious place on the coast.
Okay. And what kind of feelings did they have?
They felt like dirty or unclean.
Dirty and unclean? Were they
fear and anger? Were
fear and anger?
primary.
They didn't feel like they were getting their needs met? Yeah. And that can happen anywhere, right? Doesn't necessarily have to be in an area that is a poor environment. It can happen anywhere because they get the stigma and then they don't want to seek treatment. Or if they do seek treatment, the stigma behind that treatment, they feel like it follows them. So what we do is when we do care plans, you want to do your assessment, you collect the data, the physical, the risks, the patient problem, where you make the nursing diagnosis, the treatment plan, how you're going to take care of patients, and then you're going to do your evaluation on that. So what's the first thing you do? You take a sexual history. What is mine on? Is this how yours is? I'm missing something somewhere. Oh well, I'll leave it. So take a sexual history. You're going to ask them questions. So you're going to remember. You got to start off slow. You're going to go in and say, "Hi, I'm so-and-so. I'm going to be your nurse today. And I'm going to be asking you some questions that make you a little uncomfortable, but these are things I need to know to be able to treat you successfully and get you back to where you need to be." Then you go in and you ask questions like, what brought them here? What's their sexual history? How many partners do they have? Did they use safe precautions? Then you're going to inspect them. You're going to inspect the area and see what's going on. And then you're going to do testing. Then, depending on what they find, will be the administration of treatment according to the different STI. And you're going to educate for prevention of it happening again. So some of the statistics. In the United States, CDC estimates 20 million new STI cases occur each year. And of this rate, half occur among individuals between the ages of 15 and 24. Females have a higher rate of gonorrhea and chlamydia. Men have a higher rate of syphilis. It's found that multiple or new sexual partners without safe practice is an increased risk, but it doesn't mean necessarily they can only have one partner. And they've also found that people that have other influences like under the influence of alcohol or drugs, poverty, unemployment, low education have a higher rate of STIs.